Subacute neck masses. Subacute masses are noticed within weeks to months. Although these masses might grow somewhat quickly, they often go unnoticed at onset because of their asymptomatic nature. A persistent asymptomatic neck mass in an adult should be considered malignant until proven otherwise. 6 Because delayed diagnosis contributes to decreased survival in conditions such as laryngeal cancer, it is paramount for family physicians to recognize common presentations of head and neck cancers. 7,8 Squamous cell carcinomas of the upper aerodigestive tract are the most common primary neoplasms of the head and neck, and their metastases are often the source of cervical lymphadenopathy of unknown origin. 8 Common presenting symptoms include nonhealing ulcers, dysarthria, dysphagia, odynophagia, loose or misaligned teeth, globus, hoarseness, hemoptysis, and oropharyngeal parestheses. 8 Lymph nodes associated with malignancy are usually firm, fixed, and matted. However, any persistent cervical lymphadenopathy or symptoms in the setting of risk factors, non-response to antibiotics, or unclear etiology warrants further investigation. 7 Risk factors for upper digestive tract cancers include male sex and use of alcohol, tobacco, or betel nut, commonly chewed by Southeastern Asians. 8 Additional risk factors for oropharyngeal cancer include a family history of squamous cell carcinoma of the head and neck and poor oral hygiene. 9 A subset of squamous cell carcinomas with increasing prevalence includes those related to human papillomavirus infection, especially high-risk human papillomavirus 16. 9 10 These lesions present with rapidly enlarging, lateral, cystic lymph nodes, persistent cervical nodal hypertrophy, palatine or lingual tonsillar asymmetry, dysphagia, voice changes, or pharyngeal bleeding. 10 The population most at risk is 35 to 55-year-old white men with a history of smoking, heavy alcohol use, and multiple sex partners, especially involving regenital contact. 9 Nearly 80% of salivary gland tumors are benign and arise in the parotid gland. 1 These tumors are unilateral, asymptomatic, slow-growing, mobile masses, in contrast to malignant tumors, which may have rapid growth, skin fixation, pain, or cranial nerve involvement, especially cranial nerve 7, facial. 1,11 An interpreted or isolated preauricular lymph node is another diagnostic possibility. Excisional biopsy is the preferred diagnostic approach for these tumors following review of contrast-enhanced CT or FNAB results. 11 Persistent glandular enlargement with symptoms of xerophthalmia and xerostomia may point to Sjogren's syndrome, whereas a hypertrophied, fibrotic gland may suggest chronic sialadenitis caused by a duct stone, sialolith, or stenosis. 12 Skin cancers, especially melanoma, also metastasize to local lymph nodes. When a primary head and neck cancer is not evident to explain regional lymphadenopathy, physicians should search mucosal areas, nose, paranasal sinuses, oral cavity, and nasopharynx, for melanoma. 7 Rarely, metastases from basal cell and squamous cell carcinoma lead to lymphadenopathy. 7 Constitutional symptoms of fever, chills, night sweats, and weight loss may point to distant metastases. When metastases manifest as supraclavicular lymphadenopathy, FNAB reveals a malignancy in more than one-half of cases, with age older than 40 years being the major predictor of malignancy. 13 The most common primary malignancy sites that produce cervical lymphadenopathy include the lungs, breasts, lymphomas, uterine cervix, gastroesophageal area, ovaries, and pancreas. 13 The neck is a common area for lymphoma to present as a painless lymph node that may grow rapidly, and subsequently become painful. Early constitutional symptoms often precede development of diffuse lymphadenopathy and splenomegaly. In comparison to lymph nodes associated with metastatic disease characterized above, those associated with lymphoma are usually rubbery, soft, and mobile. 11 Hodgkin lymphoma has a bimodal age distribution, 15 to 34 years and older than 55 years 14 and rarely presents extranodally, whereas non-Hodgkin lymphoma is more common in older adults and is likely to present extranodally in the tonsillar ring located in the pharynx. 1 Contrast-enhanced CT of the neck, chest, abdomen, and pelvis helps stage the lymphoma and provides possible biopsy sites. 1 Rheumatologic diseases account for 3% of disorders presenting with enlarged salivary glands and 4% of those presenting with cervical lymphadenopathy. 15 The rheumatic entities that most commonly cause salivary gland or cervical node enlargement include Sjogren's syndrome and sarcoidosis. 15